Now, we would move on to the next debate topic, chaired by Dr. Sunanda Gupta from Geethanjali Medical College, Udaipur, on the topic Preferred Anesthesia, Regional versus General for Pre-eclampsia Patient for LSCS, by Dr. Gurudatt CL from JSS Medical College, Mysore, and Dr. Baburaj C from Medical College, Trivandrum. Over to you, sirs.
Good day to the delegates as well as the organizers of KSA. And I thank the organizers for having given me this opportunity to share the platform with two stalwarts in anesthesia. And today we have an interesting pro-con debate on anesthetic management of pre-eclamptic parturients for cesarean delivery, whether it should be regional or it should be general anesthesia. As you all know, hypertensive diseases of pregnancy, they complicate about 5 to 10% of pregnancies. And in the last 25 years or so, the incidence has increased by about 25%. And some of the reasons why maternal morbidity or mortality occurs is because of delayed diagnosis, inadequate treatment of hypertension, and its associated complications. So though protocols and guidelines encourage us to use regional anesthesia for hypertensive patients whenever possible, because preeclampsia has its own implications when you give general anesthesia. So in a dire emergency or when there is coagulopathy, you may opt for general anesthesia. So let us hear from the stalwarts what they think about this major issue about whether to give regional anesthesia or general anesthesia. So first of all, I'll invite Dr. Gurudatt to talk about whether he prefers regional or general anesthesia. Dr.
So, good morning, madam. Shall I share my screen?
Yes.
Thank you, madam, for the nice introduction. So I'll be talking about regional anesthesia is ideal for pre-eclamptic patients posted for cesarean section. You know, about 30 years back when I was a postgraduate student, I was taught by my teachers that any hypertensive disorders of pregnancy, you always go for general anesthesia. But it was not until the mid-1990s when many of the clinical trials demonstrated the safety of neuraxial anesthesia in preeclamptic patients. So neuraxial anesthesia for eclampsia in Chestnut's disease, in preeclampsia, in Chestnut's obstetric anesthesia principle, 6th edition, he says that the confirmation of the safety of neuraxial anesthesia for labor and cesarean delivery in women with preeclampsia is one of the most important developments in the past 25 years in obstetric anesthesia practice. The major advantages of neuraxial anesthesia are control of hypertension and avoidance of the need for airway management. So you see, the American College of Obstetricians and Gynecologists Practice Bulletin also says that the neuraxial anesthetic techniques, when feasible, are strongly preferred to general anesthesia for preeclamptic parturients. Even the American Society of Anesthesiologists Task Force on Obstetric Anesthesia says that early epidural catheter placement in laboring preeclamptic patients, parturients, is encouraged since it secures a means of delivering neuraxial anesthesia, avoiding the risks of general anesthesia in the event that an emergency cesarean delivery is required. It also says that early initiation of neuraxial labor analgesia is recommended in the absence of contraindications in all patients with preeclampsia with severe features, particularly in women with HELLP syndrome, obesity, and when there is concern for fetal status. So even when there is HELLP syndrome, if the platelet count is above about 80,000, so it is always better to place an epidural, and if the mother goes in for section, then it can be used instead of going in for GA in these patients. So the recent guidelines for the management of women with severe preeclampsia says that to perform neuraxial anesthesia rather than general anesthesia for cesarean section in women with severe preeclampsia to reduce maternal morbidity, this recommendation is a grade 2 plus and a strong agreement recommendation. So what are the advantages of regional anesthesia? One is avoiding airway instrumentation, providing effective analgesia anesthesia while minimizing maternal and neonatal sedation, allowing for neuraxial morphine to provide postoperative analgesia following cesarean delivery. And you know that postoperative analgesia is very important in these parturients, and allowing the patient to be present for the birth of her child. So neuraxial anesthesia is the anesthetic technique in all pre-eclamptic patients. And what are the different neuraxial anesthetic techniques we have? One is a spinal epidural or a combined spinal epidural techniques. But there was a concern with spinal anesthesia much earlier to 1990s, when they thought that the precipitous spinal anesthesia-induced hypotension superimposed on pre-existing uteroplacental hypoperfusion can be a real problem. But as early as in 1950 itself, there was a strong evidence that pre-eclampsia actually attenuates spinal anesthesia-induced hypotension. So there have been many trials after that which have demonstrated that pre-eclamptic parturients experience less frequent and less severe hypotension and actually require smaller doses of vasopressors than normotensive controls after the initiation of spinal anesthesia. You can see the famous trial by Aya et al. And actually they did this trial in 2003 and again repeated the trial in 2005. Also Clark et al. All these people, they found out that pre-eclamptic patients have less hypotension after spinal anesthesia when compared to normotensive parturients. Now you can see here, this the graph in the red shows that the pre-eclamptic mothers after spinal anesthesia, and the blue is the normotensive parturients. You can see there is more hypotension in the normal parturients when compared to pre-eclamptic women, absolutely stable hemodynamic status in pre-eclamptic mothers. Even Dyer suggested that there was little effect on cardiac output and hardly there was any reduction in the afterload after spinal anesthesia. So that's how these data taken together suggest that the use of spinal anesthesia for cesarean delivery in women with severe preeclampsia is appropriate. So in this graph, so this study was done by Hood et al. That they have compared epidural and spinal. There is hardly any change as far as the hemodynamic status with spinal or epidural. So spinal is also okay in preeclamptic mothers when you don't have time for placing an epidural catheter. So coming to the eclamptic mothers. So in stable eclamptic mothers, as long as their GCS is 14, no recent seizures treated with magnesium sulfate, and no recent seizures treated with magnesium sulfate, and no organ failure, actually neuraxial analgesia or anesthesia can be considered. In a retrospective review of 66 South African women with stable eclampsia, Moodley et al. Found no difference in maternal and neonatal outcomes in women who received epidural anesthesia compared with general anesthesia for cesarean delivery. Actually, Singh et al. So they compared spinal anesthesia in 12 stable eclamptic women, and they reported that only one episode of hypotension occurred and there was hardly any complications in these eclamptic women. So there may be situations actually like emergent cesarean delivery in a preeclamptic patient with full stomach, non-reassuring airway, in which risk of general anesthesia is sufficiently high that single shot spinal anesthesia is safer than general anesthesia despite extreme degrees of thrombocytopenia. So that means even if there is platelet count is slightly on the lower side, it is the risk and benefit ratio will be more benefits towards spinal anesthesia with a thin gauge needle rather than going in for general anesthesia and create a lot of problems for the mother. So then again, the incidence of epidural hematoma has been found to be very low in obstetric anesthesia practice. Even in this study was done in thrombocytopenic parturients, they did not find any increase in the epidural incidence of epidural hematoma. So what are the indications for general anesthesia? There are very few indications for general anesthesia, like coagulopathy, sustained fetal bradycardia with reassuring maternal airway. This is very important. If the airway is non-reassuring, it is always better to go for neuraxial anesthesia in spite of sustained fetal bradycardia, severe ongoing maternal hemorrhage, and contraindications, absolute contraindications to neuraxial technique. Now, what are the concerns with general anesthesia? There are a lot of concerns with general anesthesia, like difficult airway, hypertensive response to intubation and extubation, risk of stroke, aspiration risk, pulmonary edema, myocardial ischemia. Patient will be on magnesium sulfate, so there can be prolongation of the non-depolarizing muscle relaxant effects, and polypharmacy. There can be a lot of effects on the neonate. So, if you just see one of the studies that has been done in low and middle income countries, it was found that the GA is associated with increased complications in women with preeclampsia undergoing cesarean section. So again, failed intubation rate in obstetric patients. We all know that failed intubation time rate is very high. It is almost 8 times higher than the rate in non-obstetric surgical populations. But this is in probably in all obstetric patients. In preeclamptic mothers, the airway is so difficult, probably it will be much higher. So again, even with modern advances in airway management, the incidence of failed intubation can be almost about 1 in 443, and maternal mortality occurring at a rate of 1 death per 90 failed intubations. So it's also been found that the desaturation, oxygen desaturation during airway management occurred twice as often in patients with hypertensive disorders of pregnancy when GA was instituted for these patients. So again, in the 8th report of the confidential inquiries into maternal deaths in the United Kingdom, they have found out that the intubation failure, inadequate ventilation, and aspiration represent leading causes of anesthesia-associated obstetric morbidity. So again, in Chestnut, he clearly says, if the airway evaluation suggests a difficult intubation or risk factors for difficult neuraxial placement, like morbid obesity, scoliosis, dropping platelet count, the establishment of a continuous neuraxial technique early in labor should be strongly encouraged, so that if the mother is taken for cesarean section, then it can be converted into anesthesia from analgesia, so that GA can be prevented. So again, coming to the preeclampsia and stroke. So GA for cesarean delivery was associated with increased risk of stroke when compared with neuraxial anesthesia in preeclamptic women. There are many articles that have been presented with high risk of stroke in preeclamptic women. So a review of 28 case histories of severe preeclamptic women, they found out that the systolic pressure, blood pressure, is more important than actually the mean arterial pressure or diastolic hypertension. But you can see in this graph, especially in the study done by Hodgkinson et al. So during intubation and during suction and extubation, the mean arterial pressure itself has shot up to 160. You can imagine what would have happened to the systolic pressure. So in study done by Ramanathan et al., he also found, in spite of levodopa premedication, many of these preeclamptic mothers with induction, intubation, and incision, the mean arterial pressure was shot up and systolic pressure was much higher than 160 millimeters of mercury. They also found out the cerebral, middle cerebral artery blood flow velocity was also very high, and the neuroendocrine response for GA when compared to epidural was much, much higher in preeclamptic mothers. So with all these evidence, I strongly suggest neuraxial techniques are ideal for cesarean section in preeclamptic patients. GA carries a very high risk of morbidity and mortality. So GA can only be provided when regional anesthesia is absolutely contraindicated. Thank you.
Thank you, Dr. Gurudatt. And now I invite Dr. Baburaj, and let us see what is his point of view regarding the technique of anesthesia. Dr. Baburaj.
Is it visible?
Yes.
Good morning, respected chairperson, Gurudatt sir, and dear delegates. Okay, my job is to argue for general anesthesia for preeclampsia. Let me enumerate the potential problems associated with spinal or epidural anesthesia and concerns related to Probably the most commonest one is the hypotension, sudden hypotension, especially with the spinal anesthesia, because you need to give a block up to T6 or T4. So much extensive pharmacological sympathectomy. In the background of low intravascular volume and vasoconstriction, the incidence of hypertension is going to be more severe in patients with pre-eclampsia, and of course managed with phenylephrine, ephedrine, and so on. But these drugs are also causing fluctuations in the hemodynamics, which of course have negative effect on the mother as well as on the fetus. And the patients who are on more magnesium sulfate can have more hypotension, and the vasoconstriction responses of these drugs may be less. Now, another thing about which I am concerned is the spinal epidural hematoma. Of course, we know PH is associated with coagulopathies. HELP syndrome is associated with a low platelet count. A patient when brought to the emergency cesarean section for emergency section may be having borderline coagulation profile, and patient may be having only not maybe having a recent coagulation parameters, and they are at risk of developing hematoma. When the spinal or epidural needle passes through the epidural space, which is having the engorged epidural vessels, of course, bleeding is going to happen and compress the spinal cord, and the end result is a major disaster, that is paraplegia. And of course, if the obstetrician wants a very urgent delivery of the baby, as in case of fetal distress or cord prolapse, or any indication for rapid delivery, I'm sure spinal and epidural will take more time. Now, cerebral edema is an association with severe PAH and also patient who had eclampsia. And we know those with cerebral edema will be drowsy, they will not be able to protect their own airway, they may not be cooperative. Of course, in such patients, I don't think spinal or epidural is not an ideal choice because of fear of aspiration of gastric contents and lack of cooperation from them. Now, consent, that is a very important thing, and an absolute contraindication for any region is the consent from the patient. And if the patient says no, you can't proceed further. But what happens practically is we'll be highlighting all the complications of GA, partially hiding the problems of spinal, and finally, patient will be giving a consent under pressure. And another absolute contraindication is the skin infections, local infections, and we know patients, especially hospitalized for a long duration, may be having fungal infections, and carrying these infections deeper is not at all acceptable. Now, okay, patient gave consent, and now comes the difficulty in positioning. Here is an obese patient having a protuberant abdomen, having edema everywhere. It is very difficult to position, and even the needle passage is difficult because you are not able to palpate the spines. You don't get the feel of needle passing through various layers. And of course, our plan was to use a 27 or 25 gauge needle, repeated attempts because of difficult spinal, and finally we end up with 23 or 22 gauge needle. And the end result of these together, that's multiple attempts and large bone needle, is the post-dural puncture headache. I should say this is a torture for the mother because mother is not able to sit up because of the headache, and she's not able to feed the baby. And of course, I think with GA, this complication can be avoided. Now, inadequate level, it can happen with any spinal or epidural, and probably the surgery might have started with a level of T7. And when the surgeon is going deeper and deeper, the patient is moaning, and both surgeon and patient are struggling. And at that time, there is only one option left behind: induction of GA. Induction of GA is not an issue, but induction of GA in a hurried manner can end up with complications. The other end of the spectrum is too high levels. Of course, that can happen in obstetrics when the drug is injected during a contraction. It goes up, and the patient who was talking suddenly stops speaking, phonation is lost, and diaphragm is paralyzed. And here also you have to protect the airway by intubation. Short-term mask ventilation is acceptable, but long-term mask ventilation is not good because of the unprotected airway. The last but not least is the surgery. Due to some other reason, if the surgery gets prolonged, of course, for spinal, there is no other option. You have to supplement GA, but epidural, of course, you may be able to a supplement. Now, why GA? Now, keeping in mind the arguments, the concerns about spinal anesthesia, rebuttal anesthesia. See, when there is immediate threat of the life of mother or fetus like cord prolapse, abruption, or maternal cardiorespiratory distress, the only option is GA. And no fear of hypotension, no bradycardia, no fear of spinal hematoma and subsequent paraplegia and subsequent litigations thereafter. In a sedated patient, especially patient having cerebral edema, drowsy patient, better control of airway and respiration is possible. No question of inadequate levels or fear of too high levels. No bending. My patient is comfortable. She can lie supine with an LUT, left uterine tilt. That is enough. And no PDPH, no unnecessary bed rest, and no unnecessary hydrations, and no hurry even if surgeon takes a longer time. Now, let me tell you about my plan of GA. See, I'm fully aware that exaggerate similar response is going to happen in GA, but with drugs like titrated doses of induction agents, opioids, vasodilators, beta blockers, I'm sure I am able to control the pulse and BP with proper anesthetic techniques. And difficult airway can be managed with confidence with all gadgets. And of course, I have to adhere to the protocol. I should have the plan A and plan B and so on. The most important thing is I will be expecting the worst so that I can prepare for the best. And with an armamentarium for difficult airway ready in hand, I should prepare ready in hand. And with an experienced or knowledgeable assistant, I think the induction intubation may not be an issue. And I have short-acting agents like fentanyl, remifentanil, dex, atracurium, sevoflurane. And also I am having monitors starting from ECG to VIS. And with the feedback from these monitors, I will be giving titrated doses of drugs to the patient. I'm not going to overdose so that I'm not concerned about the delayed recovery, and accidental awareness under GA is an issue. And I am sure that I can manage with judicious use of inhalation agents. And with the titrated intraoperative drug management, keeping in mind all the kinetic and dynamic issues regarding pharmacology, I feel extubation can be made as smooth as induction. Now, I'm aware that my patient will be having residual effects of general anesthetics, so an intense postoperative monitoring is mandatory. And regarding pain management, of course, with multimodal analgesia, I'm sure I'll be able to provide good analgesia for my patient. And pulmonary embolism is another concern with GA, but with proper gadgets and early immobilization, I'm sure I can prevent that also. So with all the steps described above, I'm sure at the time of need, when there is a definite indication, I'll be able to provide a safe general anesthetic to my patient. Thank you. Thank you, ma'am.
Thank you, Dr. Baburaj. Very well argued in favor of general anesthesia. And now let's go to Dr. Gurudatt. And let's see, Gurudatt, you have 5 minutes to rebut your opponent's views.
Yeah, I know that it was very difficult to argue for general anesthesia, but Dr. Baburaj had done an excellent job of presenting regarding GA for pre-eclampsia. But I just want to talk about whatever his concerns regarding the regional anesthesia, especially first thing he said that drastic fall in blood pressure. I've already shown many of the trials wherein they have found out that there is hardly any fall in blood pressure in these patients with pre-eclampsia because circulating catecholamine levels will be so high, and also their response, especially the vascular response to these circulating catecholamines will be much higher than whatever we are going to block the preganglionic fibers that release the norepinephrine. So what has been found is there is not much of a hypotension as presented by Dr. Baburaj. So another thing is he was talking about the patients on Maxelf. So if the patients are on Maxelf, especially there are more problems for GA than the epidural or spinal anesthesia. We know that now Maxelf can really prolong the duration of action of non-depolarizing muscle relaxants. And if you want to titrate really, you require a lot of monitoring of neuromuscular junction, which hardly anybody will do it. Then coming to the epidural hematoma, already I argued I presented that there are incidences wherein they have used a thin gauge spinal needle in spite of the thrombocytes being even less than 50,000. There are articles wherein they have just supplemented the patient with platelets and they have used a thin gauge spinal needle and they have observed the patient for 2 to 3 days and hardly there is any kind of spinal hematoma has occurred. So that what is very important there is they wanted to just prevent the GA, the problems of the GA. So another thing in an emergency, yes, even in an emergency, if the airway is a non-reassuring airway, still it is always better to go for a spinal. We know that in a few years back, there was a rapid sequence spinal also was introduced. So one can definitely try a rapid sequence spinal for these patients in such a rare emergencies so that you can definitely prevent the high risk of the general anesthesia. The other thing is regarding the PDPH. So when you just think about the problems associated with GA, I don't think the PDPH, hardly any incidence of PDPH with a thin gauge needle. So you need not have to worry at all about that. And too high levels of spinal anesthesia. So definitely we have to give a T4 block. And all these days, 99% of the patients have been given spinal anesthesia or epidural anesthesia with very good surgical conditions. And hardly we have faced any problems in this pre-eclamptic, even severe pre-eclamptic mothers. I don't think that should be a concern for going in for GA, having a lot of problems. Another very important thing for GA is the difficult airway. So you are talking about, I'll give all those, the pre-medicant so that the intubation response can be definitely prevented. No, not like that. Because, when there is a difficult airway, you will be trying for many times and your pressure on the respiratory tract, especially the laryngeal area, is so high that definitely the blood pressure can shoot up and there is always a concern for stroke in these patients. So that is another problem. Plus, you are talking about titrating the anesthetic agents. If you titrate the anesthetic agents and you are giving less doses of anesthetic agents, lighter planes, and again there is a problem of high blood pressures, intraoperatively, and the patient can definitely go in for post-operative stroke or even CVA, and the patient may not recover at all. So one more thing is I want to tell is regarding GA for obstetric anesthesiologists. They hardly give GA for any patient. They are so good in spinal or epidural or neuraxial techniques. So suddenly if they have to give GA, it becomes very difficult for them. So considering all these, I am arguing towards regional or neuraxial blocks for these patients. So in an emergency, for example, now if you think that the patient has to be taken up for an emergency, so before that only one can plan and then place an epidural catheter, and if an emergency comes, you can avoid general anesthesia. So thank you so much for giving me this time for arguing.
Baburaj, now you are in the arena. You can head back on Gurudatt.
Thank you, sir. So I have few suggestions of I want to supplement my arguments regarding the hypertension you mentioned. Of course, in a planned procedure, it is not an issue. But when a patient is wheeled into the emergency, pre-existing dehydration and improper assessment, I should say coagulopathy might not have been properly assessed. In such a situation, especially in dire emergency, with the background of intravascular volume depletion and vasoconstriction, I think there is every chance of hypertension happening. And regarding magnesium, in many articles, it is written that magnesium can cause more hypotension and it can even actually obtain the response of vasoconstrictors. And actually, my concern is only about my patients who are wheeled into the OT in an emergency situation. Probably they are dehydrated and probably their coagulation is not properly assessed. In that situations, I think GA is better because I don't want my patient to have hypertension. Already there is compromise of placental circulation. I want to worsen it further. So regarding magnesium sulfate and monitors, I think nowadays most of the theaters are having workstations starting from ECG, pulse oximetry, even BIS. Our OTs are having this, not all workstations. And since I already said my motto is expect the worst and prepare for the best. Of course, I will be doing lunges, I will be expecting a coronary hand 4. I'll be expecting difficulty in ventilation, difficulty in intubation. That is why I said I will keep everything near my thing and I need a experienced, knowledgeable assistant. Without that, I may end up in trouble. And from the feedback from the monitors, I am able to titrate because if I have an NMJ, because most of the workstations are having NMJ, so I just attach and see the train of 4 count and just give atracurium according to that. I'm sure I'll be able to provide triad of anesthesia with, tailoring to the patient's needs. And regarding epidural hematoma, actually it is given in books that the reported incidence around 1.5 lakhs or only 2 lakhs. And there are reports that many epidural hematomas are underreported, not reported properly. And if that happens, even though the incidence is only 1 in 2 lakhs, if my patient after spinal or epidural lands up in paraplegia, I think it will be very difficult to manage. So in any situation where I am worried about, will my patient develop coagulopathy, I will definitely go for GA because I'm not ready to take any risk because of the attendant issues. And now regarding PDPH, of course, as you said, using small needles will prevent it, but not in all patients, but in some patients, because the difficult spinal, attempts will be more and more, and you are moving from 25 gauge, then 23 and 22. And this combination of these two can definitely cause PDPH, and I have seen many patients suffering from, even with it 1 or 2 pricks of spinal, suffering from PDPH for days and days. And the main complaint is, I can't sit, I can't drink anything, I can't eat anything. And if it happens, it is going to be a real suffering for the patient. And regarding high level, of course, that can happen, especially when you inject the drug during contraction. I have seen high spinals, but all of my patients were of normal anatomy. I managed somehow with assisting with oxygen. But in a patient with anticipated difficult airway, with all the potential problems of PH, I'm a little worried. So I think in that case, I will induce GA sooner. And regarding the, I think these are the points you brought out.
Okay.
And I would like to say that I am not for GA for every patient with PH. So my selection of patient will be depending upon the patient's condition, because I want to provide a safe anesthetic. I don't want any complication to happen. So I have to actually look into the patient's problems, patient's lab investigations, and in any doubt, of course, it is GA. I'm sure if no long-lasting problems are going to happen, of course, then as you said, I may be preferring spinal also. But it is only for selected patients I'll be going for GA, because the ultimate goal is the patient safety. Thank you.
That's a good message, Dr. Baburaj. And now a couple of questions for both of you. As you know, Dr. Gurudatt, coagulopathy and thrombocytopenia have a close association to liver derangement. And all of these have an association with the severity of pre-eclampsia. So in a severe pre-eclamptic parturient who has a platelet count of more than or equal to 70,000, so do you think you need any more lab tests here? Do you routinely do it, or you just rely on the number there, 70,000?
No, it all, thank you, madam. It all depends on the trend of platelet count.
Yeah.
Whether the trend is showing that there is a decreasing in trend, then definitely 1 hour previous platelet count is ideal. One has to get. If the trend is not fall of platelets, then even last count can be about 6 hours. Definitely the other coagulation parameters we have to go for, especially prothrombin time, INR, I have to get it. So if I am satisfied that the platelet count 1 hour before is above 70,000 and PT INR normal, definitely I can go for an epidural also, or a combined spinal epidural for the patient.
And would you want to do your liver functions, AST, ALT at this time?
Most important thing is the prothrombin time and INR, madam. even if the liver functions is slightly abnormal, and as long as PT-INR is normal, so I can definitely go, because as long as there is no coagulopathy for the patient. So that is what I want to make sure before I go for an uraxial block.
And if your patient is already on anticoagulants preoperatively, does your management strategy change?
Yeah, that depends on what kind of anticoagulants, madam, whether oral anticoagulants or parenteral anticoagulants. Suppose if the patient is on oral anticoagulants and if she is posted for an elective procedure, definitely I would like to stop these oral anticoagulants, depending on whether it is warfarin or
switched over to
coumarin.
parenteral. Yeah.
Pardon, madam?
I said they would have switched over to parenteral. Close.
If the patient is on parenteral anticoagulants, especially the low molecular weight heparin, if it is for prophylaxis, I will wait for about 12 hours. If it is for therapeutic, I'll wait for 24 hours. If I'm going in for, if it is unfractionated heparin, 6 hours. So that is what my plan will be. It all depends on whether the patient is being posted for elective procedure or emergency. Suppose the patient is on anticoagulant therapy posted for an emergency procedure, so then definitely I may have to keep everything ready. I may have to even give fresh frozen plasma, vitamin K, and then only I'll have to go for a general anesthesia. So there is no question of neuraxial block when the patient on anticoagulants is taken up as an emergency procedure. Okay. I'll go with Baburaj then.
Yeah, you switch with Baburaj. So Dr. Baburaj, a question for you. Recently, one of our newly passed out consultant was faced with a severe pre-eclampsia, and the platelet count was around 50,000. The patient was on magnesium sulfate infusion, and she decided on general anesthesia, but she was adamant that the Maxelf infusion has to be stopped. But the obstetrician was not very happy about it. So what would be your concerns here? Would you like to stop that Maxelf infusion, or you would allow the obstetrician to continue it?
No, ma'am. I will allow the obstetrician to continue it, because actually Maxelf is a golden standard for management of preeclampsia. It has got cerebral vasodilatory effect. It has got dilatory effect on the vessels. So I would like to continue Maxelf, and during GA I will take appropriate measures, because Maxelf can potentiate my sedatives, my opioids, my neuromuscular blocking drugs. So only thing I have to titrate my drugs according to the response. Of course, I need proper monitoring also.
And yeah,
so I will allow them to continue.
Uterine atony is also a cause for.
And of course, I have to check for any toxicity, magnesium toxicity, that I have to inquire with the obstetrician.
So supposing the platelet count is 50,000, she has no history of any bleeding. Would you advocate platelet transfusions?
50,000.
Yeah.
No, I will not.
What about Gurudatt?
Yeah, madam, I can definitely go if she is not having any bleeding diaxis. There is no reason unnecessarily to give platelets when the platelet count is about 50,000. And I'll definitely plan for, if there is no contraindication for spinal, I would like to go for a spinal anesthesia in such situations.
So I think that was a very interesting discussion we all had. And Dr. Baburaj also shifted towards Dr. Gurudatt. You had a more difficult job to, talk about general anesthesia, and you basically know that you also do not give general anesthesia. We all have been giving regional anesthesia. So just to conclude, a consensus from you all: it is prudent to place an early neuraxial catheter for labor analgesia. And this will, of course, avoid general anesthesia and any airway instrumentation. The second important point, what I could gather, is that neuraxial anesthesia is safe. And though it causes, even if the hypotension is there, it is very minimal and it is very amenable to the vasopressors that you give. The doses of vasopressors you require are less. The number of doses required are also less. And if a platelet count is less than or equal to 75,000, more than 75,000, it is a reasonable threshold for neuraxial anesthesia. Now, when general anesthesia is a choice for the patient, lack of time, if it's an emergency or if coagulopathy is present, what our main concern is that you should avoid any acute increase in blood pressure so that you do not cause any cerebral encephalopathy. And of course, what you need to do is you have to be careful during your intubations and extubations. And in the postpartum period also, you need to be really careful about the complications that can occur. And one other thing which we did not discuss was the intravascular volume management. There should be no preloading. It should only be co-loading. Somewhere around 85 ml per kg is enough. And we need to be vigilant in the immediate post-operative period to prevent hypertensive encephalopathies, eclampsia, thromboembolism, hemorrhage, and pulmonary edema. So with this, I think now we can, let's see what questions are there in the chat box. Thank you so much.
Thank you, madam. Thank you very much for a nice summing it.
So there is one question in the chat box I can see. Dr. Baburaj, can you answer this? What is the medico-legal implications of when you choose one technique over the other? Are there any concerns, medico-legal concerns, Dr. Baburaj?
Thank you, ma'am. Thank you, ma'am. There are medical legal concerns, and that's a very relevant question. As we discussed earlier, if any contraindication for regional is there, like coagulopathy or an urgent nature of surgery, I think GA, you have to proceed with GA. And otherwise, I think regionals would be better. Because in a court of law, the problem is the advocates are very clever. They ask only close questions. They don't ask you leading questions, right? For example, a patient after spinal, a pre-eclamptic one developed some hematoma or something like that. For the expert, the advocate's question will be, in a background of abnormal coagulation, is it advisable to give GA or spinal? So it's a very close question, yes or no. So expert have to give either say yes or no. So here, all experts are going to say no, because only spinal, only GA is indicated. So in such a scenario, I would say, if you have any doubt regarding the coagulation status, better go for GA. For example, if the patient has been wheeled into the OT, for an emergency and patient is not having any recent investigations, and you are in doubt whether patient has a coagulopathy, because you need platelet count in the form of a trend rather than a single value. The trend will give you an idea whether platelets are going up or down. So if you don't have all these and obstetrician in a hurry to operate, I think don't take risk, go for GA. Otherwise, I think regionals are much safer, because there is no need of manipulation of airway. And the same question is applicable for the urgent nature of surgery also, because obstetrician wants to deliver the baby immediately because of some other reason. And during the attempts at regional, we take some time, and unfortunately the baby dies, and they'll be blaming us for the delay. So in such a situation, actually you have to balance, between the risk and benefit. I think that is the best method. So medically, it is relevant. We have to go for a defensive practice, I would say. Thank you.
Dr. Gurudatt, do you want to add something to that?
I fully agree with whatever Dr. Baburaj was talking about. And definitely we can always depend upon the textbooks, the guidelines, the advisory. So whatever that is there, if we just go with them, I don't think medico-legally will be having any problem. So because, as long as the patient has got 70,000 and above the platelets, and ideally in many of the books also says 1 lakh, but they also say that anything above 70,000 is still okay for regional anesthesia. And even for spinal anesthesias, many of the articles have come out with 50,000 and above. But provided we have to show that in the case sheet also, we'll have to write down that what are the problems associated with GA. So if we write down all the problems associated with GA, the risk benefit ratio towards the regional anesthesia, definitely we can go for regional anesthesia. And if there is already an indwelling catheter is there, which is functioning epidural is there, definitely even in an emergency also, you can convert that into an anesthesia rather than going in for GA. So as long as we go with the guidelines, we go with the textbooks, I don't think there should be any problem medically.
And we should be careful that a good counseling is really very important. You should keep the communication lines open.
Yes,
that is so very important. And like Dr. Mukul Kapoor has said, that you should follow the guidelines. They always support you if you are held up in a medico-legal situation. So with this, I think we wind up this session. Thank you very much, Dr. Gurudatt and Dr. Baburaj. It was an excellent session. Thank you, organizers.
Thank you.
Thank you.
Thank you, ma'am. Thank you.